Hello guys, hope you're all okay. You're all enjoying your life and you're also enjoying practicing radiology. I'm Dr. Arshad Awan with my radiology and ultrasound teaching videos. Today, the topic of discussion is ventriculomegaly or focal lateral ventricular enlargement or dilatation. In the setting of senile brain assessment, CT scan shows ventriculomegaly, that is because of the secondary degenerative changes of the brain parenchyma. Because of that, the ventriculomegaly ensues. In pediatric setting, obstruction at the level of foramen Monro or aqueduct stenosis also leads to dilatations of the ventricles. In the adult age group, usually space-occupying lesions or any glioma may lead to ventriculomegaly. What are the differential diagnoses and how the Evans index play its role towards the diagnosis? Let's look for these images. Before going to talk about the ventriculomegaly or focal lateral ventricular dilatation, it would be better to brush upon the anatomy. And here in the view you can see anterior view of the ventricles and the lateral view of the ventricles. On the images you can appreciate this blue color lateral ventricles, especially anterior horn, and then beneath that there is interventricular foramen which is communicating with the third ventricle, and that is called as foramen of Monro. If you go down, so you will be able to appreciate cerebral aqueduct which is continuous with the fourth ventricle. So communication between the third and fourth ventricle is bound by the cerebral aqueduct, and downward it is communicating with the central canal. So this is the anatomy of the ventricular system. Another image beautifully explaining the ventricular system. You can appreciate the anterior horn, and you can also appreciate the foramen of Monro which communicating the anterior horn or lateral ventricle to the third ventricle. So choroid plexus can also be seen. Choroid plexus function is to secrete the CSF, and in view you can see the cerebral aqueduct and fourth ventricle. Another elaborative image explaining the parts of the lateral ventricle. Here again you can appreciate anterior horn, but beside this you would be able to see the central part or body of the lateral ventricle and posterior horn. Between the lateral ventricle and the posterior horn there is the area which is called as collateral trigone. Third ventricle and foramen of Monro is visible. Cerebral aqueduct can be easily seen, fourth ventricle and the central canal. The anatomy of the ventricular system has already been discussed in the previous images, but here again you would be able to see the lateral ventricular 5 divisions. Anterior horn, or it is also called as a frontal horn. The nomenclature has been given to their respective lobular presentations. So anterior horn lies in the frontal lobe, so that's why it is called as a frontal horn. Inferior horn, which is the temporal horn, and body of the lateral ventricle, there is trigone of the lateral ventricle which is also called as atrium, and the posterior horn which lies in the occipital lobe. So that's why the nomenclature has been given according to the presence of the lobe or communication with the lobe, so that is the occipital horn. Before going to label the ventriculomegaly as a pathological process, you should have to have this in your mind that there are certain anatomical variants, like including coarctation of frontal horn or body usually regress soon after birth, but if it remain persist it will appear as a focal dilatation. Aplasia or hypoplasia of posterior horn, it's also common, and this is another anatomical variant. Asymmetric lateral ventricles also happens in a few beings, and cavum septum pellucidum. So these are all the anatomical variants. Before going to jump into the conclusion that this is a pathological process, you should have to have the idea that there are certain anatomical variants which you will come across while reporting the ventriculomegaly. With regards to the ventriculomegaly, Evans index is worth mentioning. It is the ratio of the maximum width of the frontal horn of the lateral ventricles and the maximum internal diameter of the skull at the same level, and this is usually seen on the axial images. As far as the interpretation of the Evans index is concerned, it ranges from 2 to 2.5 considered to be normal, and 2.5 to 3.0 possibly or early ventricular megaly. But if the Evans index is greater than 3, that is considered to be a ventriculomegaly. However, in the normal day to day practice, we do not apply this Evans index because of certain factors, or sometime you can visibly see that there is a ventriculomegaly, so that's why nobody is calculating the Evans index. But as far as the theory is concerned, you should have to have this in your mind, that this is the criteria for the Evans index to be applied for the ventriculomegaly. CT axial image of the 17 years old man. In view, maxillary sinuses are unremarkable, no feature of sinusitis. Nasal ostiums appear unremarkable. If you goes upward, you would be able to see that both orbits are unremarkable. There is no orbital abnormality. And then look for the brain parenchyma, normal gray and white matter appearance. Here you can find the pathological process, and that is disproportionately enlarged temporal horn of the right lateral ventricle. There is no clearly visible anterior horn and there is no clearly visible posterior horn on the right side. However, the left side lateral ventricle is slightly compressed, so there is likely possibility of either inflammation or infection or partial obstruction at the level of foramen of Monro. So MRI advice is the next. MRI should be advised as a next modality to find out, to rule out whether there is any space occupying lesion or any cause of the partial obstruction at the level of foramen of Monro. As far as the cisterns are concerned, normal cisterns, there is normal third ventricle, there is normal fourth ventricle, there is no cisterns dilatation. So this is the example of the focal dilatation of the lateral ventricle.